The world is changing extremely fast right now in ways that can feel both exciting and overwhelming. So, how do we find balance in all of this? I'm Stephanie von Bismarck, activist, author, and digital educator. Welcome to my podcast, where each week I sit down with some of the world's best thinkers, trailblazers, and extraordinary people to find ways to help us all thrive and answer the big question, how do we manage? Today's episode is one I've been wanting to record for a long time because it's about something half the world will go through, and yet it's still surrounded by misinformation, silence, and stigma. We're talking about menopause. And joining me is someone who's doing more than almost anyone else to change the conversation around it, Dr. Naomi Potter. She's a medical doctor, menopause specialist, and co-author with Davina McCall of the best-selling and award-winning book, Menopausing. She's a mythbuster, a fierce advocate for women's health, and an expert voice in a space that desperately needs clarity and compassion. So, how do we manage menopause? Let's find out. Dr. Naomi, I think it's really fantastic that finally menopause is something that is being talked about and enters the public conversation. Because if I try to think back when my mother was around that age, I remember her struggling really with her health for quite some years. And I know that she went from different doctors and she just had certain things. But I know that most likely she never got any help around perimenopause and menopause. And I think it's fantastic that as a new generation, we now finally have chances looking into the symptoms and what it actually can cause.
Perimenopause is terminology that really has only been used in the last 5 years. You were kind of either not menopausal or menopausal. Like that was kind of how it used to be. Whereas now we understand that hormonal symptoms from your ovaries not working as well can start for years before your last period. And that's all perimenopause. And whatever we call it, it doesn't really matter what name is given. It is those symptoms that come about from your ovaries not functioning as well as they used to. You are in menopause if you've had 12 consecutive months with no period. That means that you are menopausal. But the perimenopause is any time before that where you are having symptoms because of your hormonal fluctuations or that decline.
Yeah, and I think that's super, super important to talk about because this perimenopause, if you think about the old idea of menopause, it was around 50-ish, depending on where you come from and all of that, and how you sort of genetically structured. But the perimenopause can start really, really early, right? From approximately what age?
It's highly variable, just like the age of menopause is highly variable. We have a number of women in clinic with early menopause, and some even younger than 40. And some like in their 30s and even in their 20s. It can happen at any age. Typically, perimenopause would start mid 40s. But it's so highly variable. We don't really like to kind of put a label on it.
How does it typically present itself?
I think the rules are there are no rules when it comes to hormones, but there are very, very typical symptoms of perimenopause and menopause, and that would be hot flushes, night sweats, periods changing. So those are the three biggies. But in addition to that, you can literally get symptoms from top of your head to tips of your toes, even when you are still having cycles, because estrogen affects every organ system. So if you're experiencing symptoms that you can't quite put your finger on what that might be, particularly if they're cyclical, particularly if you're not feeling quite yourself, because it kind of tends to have that kind of global effect, then I just say have your menopause radar out. Like if you think it could be, then there is a good chance it could. There are a lot of symptoms that overlap with other conditions that means that you might end up having investigations to exclude other causes. So, for example, palpitations is a very common symptom in perimenopause, but it can mean that there's other cardiological things going on. And so you would be investigated. You would have an ECG, you might have an echo, you might have your thyroid function tested. But when you kind of draw a blank on other underlying causes, that's when you should think, well, could this be hormones?
I know because I myself had one of those weird symptoms, like some, numbness in the mouth, like a sort of numbness of the tongue or something. And there's nothing wrong, but it might be just hormonal changes. And I was reading up upon that, and then there's something everyone thinks about, night sweats or hot flushes, but there is also such a thing like cold flushes. Is that true?
Yeah, absolutely. It's literally just the reverse of a hot flush.
Yeah, and a frozen shoulder.
So frozen shoulder is a musculoskeletal condition, but it definitely seems to be worse, or you see more of it in perimenopausal and menopausal women.
Tell me a little bit more about the other symptoms. So we talked a little bit about the weird symptoms, perimenopause, which I also find quite interesting, is that notion is that it really seems to be, it's like a roller coaster sometimes, because you can sometimes literally feel your own body, going up and down. So what happens there? Is it just trying to manage that transition somehow? And then so like sometimes it feels as if there's too much estrogen, and sometimes there's too little, and all of that.
The perimenopause is definitely the hardest part in terms of how we manage patients and their symptoms. So I always say this to patients, like when they're very fearful that it's never going to get better. I said my clinic is filled with women in their 40s and early 50s. It is not filled with women in their 60s, 70s, and 80s who are coming to me with their very troublesome menopause symptoms.
Yeah.
It's the turbulent time of the perimenopause that is the most problematic.
Mm.
And HRT can smooth that out. And I think that's probably how it works best, is just by smoothing all of those fluctuations out or papering over them. But it doesn't always last. So we have patients that come to see us that are fine for a year, and then their symptoms come back, or they get side effects, or something changes, and you make an change to their dose or their regime, and then they're okay again, and then they come back again. They're just like, when's this going to end? And then it does. It's we see it like that a lot. A lot of women think, I just want a quick fix. I just want something to make it better. But you really need to. So HRT is a big part of it, and it's the gold standard first line treatment. But in addition to that, and even for women who can't take HRT, you have to look at somebody's lifestyle, because lifestyle choices make a big impact on symptoms and symptom severity. So things particularly like alcohol, caffeine, stress, sleep, diet, exercise, smoking, all of those things, if you don't get them right or you do them wrong, can make a massive, massive difference. You can have somebody who is fit, they eat well, they're on their HRT, but they just can't drink half a bottle of wine anymore, and it means that they wake up at 3:00 in the morning and they feel very anxious, and then the next day is a write-off, and then you just spend the whole of the rest of that day waiting to go to bed again, and you can very easily end up in this cycle whereby you're so anxious that you have a couple of glasses of wine, but then you wake up anxious and you spend the rest of the day anxious, that the only thing that takes away that anxiety is those glasses of wine, and you can easily perpetuate that. So It's looking at all of those areas of your life.
Let's talk HRT. So what has to happen? How do my blood markers look in order to start HRT?
In this country, if you're over 45 and you have symptoms that are typical of perimenopause or menopause, you don't need to have blood tests to make the diagnosis. It's a clinical diagnosis. We just go on history.
Okay.
And we can start HRT based upon that.
Okay.
And that would typically be estrogen, and then if you have a uterus, progesterone or progestogen as well. If you're under 45, then we would often do blood tests primarily to exclude other causes. But also, particularly for younger women, it's nice to try and prove it as a diagnosis, because sometimes you will do additional things like get bone scans or autoantibodies or genetic testing, that kind of thing. But the trouble with blood tests is that they are not always that accurate.
Okay.
So it can be, people can rely on them, and then they don't always give you that reassurance of a definitive diagnosis.
Yeah. I mean, there was for a long time there was such a thing about HRT because it was causing cancer, or that was anyway the notion of it. But that has changed a lot. So tell me a little bit about that and why has it changed?
So there were a couple of big studies that came about in the early 2000s that suggested a strong link between using HRT and developing breast cancer, as well as other things, as well as increasing the risk of heart disease and increasing the risk of stroke. But since people have gone back and they've looked at those studies in depth, they've realized that a lot of the data was flawed. So they used the patients that they looked at to draw those conclusions were either much older than your typical menopausal cohort. So they'd been for a number of years without estrogen. A lot of them were overweight. A lot of them were smokers or ex-smokers. So they weren't your kind of typical patient that you would start on HRT. The other problem was that they weren't using the modern HRT that we would typically start somebody on now. So the estrogen through the skin and the body identical micronized progesterone that is considered the safest and the most breast friendly. And we still lack a lot of data on these safer on the products that we know are safer. We lack kind of big studies. So I mean, breast cancer is scary. Everybody knows somebody who's had breast cancer young. And nobody wants to do anything that's going to put their risk of breast cancer up. But we just need to make sure that what we're telling people is true. And we know that, if you drink a couple of glasses of wine a night, then you put your breast cancer risk up. If you don't exercise for a couple of hours a week, then you put your risk of breast cancer up. If you do exercise, you bring your breast cancer risk down. Obesity puts your breast cancer risk up more than anything else. But it's just putting it into perspective. But the modern HRT is thought to be very safe. But breast cancer is scary, and I think it's all kind of wrapped up in lots of there's lots of breast cancer narrative and fear, quite understandably, and HRT is sometimes kind of bundled into that, especially because a lot of so about 80% of breast cancers have an estrogen receptor as part of them, and the language that is used to describe those breast cancers, people say it's estrogen driven. It's HRT that's caused it. Well, estrogen can make it develop and make it grow faster, but it doesn't make it start in the first place. That's the difference. That's the nuance. So it's just about really understanding how it all works.
But is there also a danger in if you, for example, let's say you weren't menopausal, that wouldn't even happen. You would, as a woman, always have estrogen in your blood. So there would always be a certain risk, or is it just that add-on?
So HRT would if postmenopausally, would raise your estrogen significantly. We do have little bits of estrogen around postmenopausally because it's produced in fat cells, which is why if you have women who have estrogen-dependent breast cancers, you're given medication to completely get rid of all estrogen, completely block it. But there is a definite difference postmenopausally to the women on HRT and those who don't have HRT in estrogen levels, definitely.
So just for short question, who are those who cannot use HRT?
It's always an individual discussion of risks and benefits. So if you have women who have active estrogen receptor positive cancers, so whether that's breast cancer or endometrial cancer, those are the two big cohorts of women where you would really think very hard about giving HRT. You have some women whose lives are so impacted by their symptoms that you sometimes, on occasion, have conversations about using HRT even in those instances. But those would be your typical group where it would most commonly be a no.
I also read somewhere that using HRT is also really helping a body prevent from other illnesses to develop. Tell me a little bit about that.
So we know that estrogen is protective. It protects bones. We know it maintains bone density. It's cardiovascularly protective. It keeps blood vessels nice and flexible and clean. It keeps blood pressure low. It helps with fat metabolism, cholesterol, sugar, body composition, metabolism. So we know it is protective. At the moment, we don't have guidance to say you should use it as a form of prevention. We don't. That's not what our kind of governing bodies are saying at the moment. Whether or not they change their minds in the future, I think it's more than just medicine, because there is a. If you say every woman should be on HRT, it's very, you are medicalizing menopause. You're kind of medicalizing a kind of natural process, and that's where there is so much debate. And there's debate at the moment about it. It's like, menopause is natural. Women should just go through it. All our ancestors before us did. But then there is the flip argument of like, well, if it's available to us, why shouldn't we use it?
Absolutely. How long does a woman typically take HRT? Is it just an ongoing thing or is it a window?
This is, again, it's kind of being discussed at the moment. So we say that for every woman on HRT, every year they should have a conversation with their prescriber about the risks and benefits of staying on HRT and the risks and benefits of coming off HRT. And some women are choosing to stay on it longer and longer and longer, and they don't ever want to come off it. Others find that it's a bit of a hassle. Maybe they can do without it. They try to come off it, they feel fine without it, and they choose to come off it. So it's very, very individual.
I know that also the mental health impact is quite big because those hormones are usually affecting the mental system. And I know that very many women, probably up until today, but at least in the past, were actually prescribed antidepressants for that time. Was that a proper misdiagnosis?
I don't think it was I don't think it was like a misdiagnosis. I think it's like GPs want to help, and the tools that they are used to using and they're comfortable using are antidepressants. They weren't used to using HRT so much. Women do present with anxiety and depression in perimenopause,
Yeah.
and using antidepressants is not first line treatment. It does sometimes work. It probably doesn't work as well as using HRT does. And I think that's one of the things that we've really noticed a change in prescribing habits, is that GPs are now more comfortable using HRT first line, whereas in
Okay.
the past it was very common to have antidepressants first.
How do I know what I need? Will you determine that, or is it playing around and how much of what I need?
It depends. Yes, so it totally depends on your history. So it depends on whether you're a hormonally sensitive person, whether you've got any other underlying medical conditions, things like endometriosis, PMS, fibroids. It depends on how old you are, whether you've got things like osteoporosis that we want to be mindful of. And then in terms of product and regime, it will depend on whether you're still having periods or not, but also what your preference is. Do you want to use something that goes through the skin, which is the safest way of doing it, but not everyone wants to use a product that's on their skin or going, through their skin. So it's very individual. It really just depends on you have. That's why we have to have long conversations with patients, and they normally know. By the time you've got to the end of that conversation, they normally know. Oh, I want to try, a patch or a gel, or I definitely don't want anything on my skin. I prefer to take a tablet. It's very individual.
And then you have to play around a little bit with the dosage that you sort of find your rhythm, right? Or is that always the same dosage?
No, it varies very much. It varies between individuals, and it can also vary for that individual. So, and some of that is trial and error. Like, no, you can't guess. You can't get it right all the time. You can make an educated guess. It's why it's kind of an art as well as a science. And patients sometimes get really frustrated that they come to see you, they want their answer, they want to go off and not have to think about it ever again. And it can be like that, but often it requires kind of tweaking.
So now we've been talking about estrogen and progesterone, but I know that sometimes also testosterone is administered. Why that?
So testosterone is a female hormone, and not everybody realizes that, but it is definitely a female hormone. And it declines as we get older. So it peaks in your 20s, early 20s, and then declines variably throughout a woman's lifetime. Some women really notice a big decline, others don't. Some women do have a bigger decline, others don't. And at the moment, the guidance says that if you have a distressingly low libido and you're on HRT and your testosterone is low, then using testosterone can help with that as a symptom.
Is that the only area, sort of the low libido, or is there other areas as well?
Well, anecdotally, we have a lot of patients who report that it helps with other things. So muscles, laying down muscle, body composition, mental health, cognitive function. We haven't got robust data that proves that, but who knows whether in the next few years we will get that. It divides opinion in the menopause world, and I think we will know in time. But we see a lot of patients who do report it. But just because somebody reports it doesn't mean that it is actually what's happening. So yeah, it's a kind of we will see. If you ask me what I think is happening, I think testosterone does play a role in other things other than libido. But I can't sit here and say it definitely does.
Yeah. So I'd love to hear from you how you actually got into the field and how you started engaging more in that topic.
So I was always interested in women's health. I really like having kind of well people that you can properly fix. And so I was a kind of women's health GP, and I had a big kind of female patient base. But I was visited by one of my patients who knew a lot about menopause. She worked in the menopause field, and she came to me for help with her menopause. And she basically told me what she would like, and I'd never heard of anything that she was asking for. And it really frightened me. And I just thought, how can I be the women's health GP when I don't know anything about what she's just asked me for? So I went away and got some training, and then became known as the person you go and see if you have menopause issues, and the receptionists all sent patients to me. And then it just kind of snowballed, and I did a bit more training, and then more patients came, and then it just kind of carried on like that. And I just loved it because I had patients that would come to me really in desperate need for help, and I could really help them. Whereas other patients, like, you patch them up and you kind of cobble together things, but you never really, really get them better. But you do with this area of work. So kind of selfishly, it's very satisfying because you get great results. So that's how I got into it.
That's great. But if you look at your training, was there nothing around menopause?
There really wasn't. I mean, I trained a long time ago. I was at medical school in the late 90s and early 2000s. We didn't have any training at medical school at all. And I did obs and gynae career training, and there wasn't any training then. And then it coincided with the time that some very kind of damaging studies came out that really prevented HRT from being prescribed because of the links that were associated by that research. And so I guess it was just kind of thought of as almost like aging, that there's nothing that you can do about it. And so we didn't have any training in it whatsoever. And it was only much later that I got formal training in it.
I still find that shocking to today, that this just been so many millions of women just dismissed as, as whatever they were going through, difficult, depressed, God knows what, anxious. I know that you also co-wrote a very successful book called Menopausing with Davina McCall. Whoever listens from the outside is a very famous British media personality. when you launched that book, what sort of feedback did you have?
Oh, the feedback was incredible. I mean, I didn't know what to expect at all. I just, because it was just like what I do. And I didn't know, I certainly was not expecting the response that we had. I mean, it was just wonderful. It was really wonderful. And to be able to make a difference and um, to know that so many more people had access to kind of simply digestible information that then they can use to help themselves. So it was almost like an unreal time. It was strange, but it was brilliant.
Yeah. Do you think something has changed? Is there some training that is now integrated in a general sort of medicinal career, or are a lot of people or a lot of women still dismissed?
I think there's been a huge change, absolutely huge change. So when I first set up my clinic about 6 years ago, I would have like the patients would come to me with very, very basic, simple menopause issues. Like they would say, "I've got hot flushes and night sweats. I'm not sure what's going on." I'd be like, "I think that's probably menopause." um, and they'd be like, "But my GP's never heard of it." It's like, "Okay, well, we can sort you out." Whereas now we tend to get much more complex patients, which is completely appropriate. Patients with either complex medical histories or bleeding issues or hormone sensitivity issues. So I think I suspect a massive amount of self-learning's gone on because GPs tend to be kind of proactive people, and they do their best to kind of keep themselves up to date. So that has happened. There is still a cohort of women who cannot access menopause care on the NHS because they either get a resistant GP or it's too hard to get an appointment, or there are still these myths perpetuated about whether or not you can take HRT. And if you can't take HRT, then GPs don't tend to know what to offer. So it's not perfect, but it is better.
Let's talk a little bit about the stigma or something. The fertility is sort of declining, and it's a little bit of a probably it has had a little bit of a negative connotation, whereas in some Asian cultures, it's actually a transition into power and strength, sort of from motherhood to matriarchy. What is your take on that?
I think it is still stigmatized, especially in kind of Western culture, where everything is about being young and beautiful and fertile, really, isn't it? All of our images and messaging and kind of the cultural narrative is you've got to be young and slim and beautiful. And as you get older, you are then considered less valuable to society.
Yes.
And so by being kind of overtly menopausal, you're basically telling everybody that that's the case. So I think there is still stigma. I mean, much less than it used to be, much less. But I mean, I think we really can thank a lot of our well-known public figures for speaking out and taking a massive risk with their own careers, but by saying, this is me, this happened to me, I'm perimenopausal or I'm menopausal, and look at me, I'm great. So I think we have a lot to thank because they took big risks, really big risks by doing that.
Absolutely. But I still think it's impressive how little that is happening, because it's millions and millions of women. And I sort of like that notion of estrogen, and I'm just putting it in exclamation marks, of being the bullshit hormone. Because as it declines, women, also take less bullshit. I'm sorry to say it that way, but it sort of helps from creating life, but somehow creating legacy or wisdom. So women sometimes tend to get stronger after that period, right?
I think so. But I don't know whether that's just age or whether that's estrogen, because I see a lot of women who are like that, but yet I know they're on HRT, and so it's like
okay. It's also a life experience, perhaps.
Yeah. It's a tricky one. I think it will be fascinating to see what happens over the next few years. What happens to is menopause having its moment now, and in 10 years' time, will no one be talking about it? What will I don't know, the early 30 somethings of today make of it? What will they say about it?
Well, probably, ideally, it's not going to be such a topic. It's just going to be one of those, transitions that just happen to women. And then there will be a lot of help, which a lot of women in the earlier days didn't have. So I
Mm.
think once you reach that point where you go to the doctor and say, this is how I feel, and then you're actually properly treated, then probably there's no need to make such a big fuss out of it anymore. But until now, that actually hasn't happened. That's why this movement is so incredibly important.
I hope so. I hope so.
Yeah.
That would, yeah, I mean, that would just be amazing.
And also for those younger generation, young women to understand that this is something that can happen and it comes along with all sorts of weird symptoms and side effects, and it just doesn't happen to you with hot flashes and night sweats around 50.
That is so important. Yeah, and girls need to be taught about that in school. So it's just something that they go through life knowing that it's not just about hot flushes and night sweats, because it would save so much suffering if they knew that.
Do you also say, because physical exercise is a big component to also help in that transition, especially, I think, the building of muscle strength?
Definitely, I think I mean, there are so many different benefits to exercise, not just muscle strength, but also the mental health benefits. And there are definitely women who are so fatigued and in such like pain, joint pain, muscle pain, that they can't exercise until they've got their HRT. Like, you can't always exercise your way out of symptoms, but equally, HRT is not going to solve the fact that you don't move ever. That you're not fit. That you're, it's definitely something that they should be used in tandem, and everyone needs to move. Our sedentary society needs to change.
That's a very general and very important statement to make, with or without menopause, I'd say.
Yeah.
Is there anything that you ever came across that sort of helps? What do those people who cannot take HRT or from a natural medicine, have you ever looked into that? Are there some herbs or some remedies that actually sometimes work?
There are lots of options. It depends really on what somebody's symptoms are, but there's options. Well, it can be kind of divided up into different categories of help. So there is non-hormonal medication that can be used, just target specific symptoms. You can use herbal remedies. Some things just over the counter can really help. You can use psychological therapies. So things like cognitive behavior therapy, hypnotherapy, even things like acupuncture and Reiki have a role. So there are other things that can be used that are not hormonal and that are safe for everybody.
So it's really that message out there, because like, do not, don't just put up with it. Or that's what a lot of women have been told, right?
Yeah,
Uh,
absolutely. There's so much that can be done. So much can be done.
yeah.
And yeah, I often see, like, on my Instagram feed, I've got breast cancer. What about me? There's nothing that can be done. And there is lots that can be done. And we're learning more, and new medications are coming out. But also we're learning much more about lifestyle. So there is lots that can be done, although they very much feel like a kind of left out of the conversation, because so much is about HRT, because nobody knew about HRT either. But there's definitely is room for everybody, and stuff that can help everybody.
Tell me, Dr. Naomi, myth or fact? Well, one we probably already answered. HRT causes cancer.
That is a myth. I mean, there are certain. It needs to be caveated, really, in that if you use estrogen on its own for a very long time without progesterone, so without a kind of buffer for your endometrium, that can cause cancer. That can cause endometrial cancer. Whether or not using the new types of HRT, and whether or not that causes breast cancer, if it does, it doesn't increase the risk by very much. But it could easily not cause an increase in breast cancer.
Okay.
But yeah, just to kind of probably needs just a bit more of an explanation about whether something is true or not.
Okay. Next one. You can't get pregnant during perimenopause.
You absolutely can get pregnant during perimenopause. That's an easy one. Seeing women pregnant in perimenopause is really distressing when those pregnancies are not planned, and it's using contraception is really important. I have this conversation with so many women who are just like, oh, it'll be fine. It's like, it's fine until it isn't. So you are considered, so over the age of 55, you're considered, the risk of pregnancy is so low that you don't need to worry about contraception. If you're using HRT and you start HRT in the perimenopause, you won't know where you are, because as soon as you give somebody hormones, then you'll probably have a bleed, and then you don't know where you are in terms of your periods. So the safest thing to do if you're on HRT is to use additional contraception. If you're over 50 and you've gone for a year without a period, then you will be considered postmenopausal, and then it's safe to not use contraception.
Okay.
But if in doubt, please use contraception.
Okay. Why are those pregnancies distressing?
Because women are often not expecting to get pregnant. They've often had their families. They may well have a young family, and then they have to make a decision about what to do. And nobody wants to be in that position when they're not expecting it.
Yeah.
The chances of having a complicated pregnancy and miscarriage are much higher with older women. And it's just something that if you're not looking to have a baby, it's just kind of best not to be in that position in the first place.
Okay. Next one. Hot flushes are the worst symptom.
They can be for some people. For some people, they can be awful.
Yeah.
But it's very individual. I think probably mood, if you have bad mood symptoms or psychological symptoms, I think those are possibly the most distressing. But it's so individual.
Why is it this is not a myth or fact? It's like, why is it so important also for men to understand this?
Well, we see a lot of relationship breakdown in whether it's as a direct result of perimenopause. It's normally as a result of a number of different factors, but I think menopause just kind of plays a significant part. And I think if men understand, then they can listen and they can help and they can be empathic. Whereas if they don't, they often think, oh, this is all about me. She doesn't love me anymore. This is, and then relationships break down. So I think it just enables men to be able to communicate and to offer support. Whereas if they don't understand, it's much harder.
Yeah, I think it's very important to understand. Knowledge is power, and then you can act and do things right. Is there anything I asked that most of my guests that you do on a regular basis that is like help manage your day any better? Like is like a ritual or something that you do?
I run.
Okay, exercise.
Yeah, I run. So I run. I like park run on the Saturdays. I'm slightly obsessed by that, and I run around a local park with one of my friends about 3 or 4 times a week. And we always say at the end of our run, like, whatever happens for the rest of the day, we've just run around Richmond Park. We're amazing. Doesn't matter. Like, we've done this today, and it's true. Like, if you've done something like that in the morning, then whatever the day throws at you, like, at least you've achieved one thing.
Yeah, and it also sets you up with a more resilient sort of attitude, right? For whatever comes. Thank you so much for joining me today. It was a wonderful conversation. We learned so much, and I wish lots of success and keep up the great work.
Thank you so much. Thank you for having me.
Thank you so much to Dr. Naomi Potter. What a great reminder that menopause is something that needs speaking up about, because it impacts so many more of us than just women currently experiencing it. I hope you'll find this episode useful whoever you are. For more information on Naomi and her work, check out the show notes, and please click follow for more topics that affect each and every one of us. Thank you again for joining me on How Do We Manage?